贵宾早安！欢迎大家参加中央研究院2016年第30届新科院士生命科学组演讲活动。今天非常荣幸能邀请本院副院长王慧君王副院长为大家致辞，请大家以热烈的掌声欢迎王副院长。
Good morning. I'm very pleased to have this opportunity here to start up this very happy and important event in Academia Sinica. Now, this event has a long tradition that I don't remember when did it start, because I don't remember I participated in this, but in any event, I think this is a very nice tradition to introduce the newly elected academician in life science to deliver their achievements, so to speak. And so here we have a chance to hear their wonderful achievement in research and other accomplishment. So now, this year, of course, is a turbulent year for Academia Sinica, and we have many events going on, but we hope things have settled down, and we have seen how do you call it? Strawberry moon last, I think, 2 weeks. So you won't see it for another 16 years. And anyway, so this, I think this year's newly elected academician have many, in many fields, they are all the top-notch experts, ranging from viral infections, inflammations, and all the way to system biology, well, actually synthetic biology. Our new president is here, and so he will deliver his talk on synthetic biology. And we also have Dr. Gao in plant biology. So we have a wide range of interesting topics here. And of course, this event is organized by our academic affair section in Academia Sinica. So we thank their help in organizing this. And of course, this has a tradition being hosted by IBMS. I noticed they have a new logo picture here. And I think this is a view from the new agricultural building. They're looking down here. It's a wonderful picture here. So I think this will be a very fruitful day, and I look forward to it. But unfortunately, I have to apologize. I have to move to Taichung after this, and so I wish you have a very successful conference here. Thank you very much.
首先，我们就恭请第一场演讲的主持人，本院记忆体研究中心主任陈仲轩院士，请掌声欢迎。
President, Vice President, good morning, everybody. It's my great pleasure and honor to be here to introduce our first speaker, academician, Dr. 张美惠院士. 张美惠院士 is current position is Distinguished Professor at National Taiwan University and also Director of the Hepatitis Research Center in National Taiwan University Hospitals. And Dr. Jiang got her MD degree from National Taiwan University. And since then, she devoted her career to National Taiwan University and National Taiwan University Hospital. And she achieved so many great stuff, it's really difficult to introduce her in a brief time. However, I can only give you very brief some highlights. And she currently is the president of many important professional organizations, including International Association of Pediatric Hepatology and also nutrition, and also International Organization of the Cancer Prevention, and also president of the Taiwan Pediatric Association. In addition to that, Dr. Chang has many awards and honors. It's difficult to finish them in here. I just want to name a few. And she got the award of this Sherlock Award of the International Association of Pediatric Research, and also the International Association of the Hepatology Research, and she is also have the award of the Taiwan Pediatric Research Association. And in terms of domestic award, she has so many. She got almost every one of them, and she has 6 awards from NSC. I never saw any person like that. And really super. And she is also got the award of the 10 most outstanding young lady scientists in Taiwan, and also 10 most outstanding achievement in terms of the lady scientists in Taiwan too. Yeah. And in addition to that, has Hojingdui Award and this and that. I just could not remember. My memory is deteriorating. Yeah. Okay, so in addition to all this outstanding achievement, everyone knows she has really outstanding achievement in terms of clinics and also research, and saved thousands and thousands of lives in Taiwan. And today, her topic will be cancer prevention from fetus to adults. And let's give a very warm welcome to Dr. Zhang.
Thank you so much, Director, Academician Chen Zhongxuan, to your very kind invitation and introduction. President Liao and Director and Academicians and colleagues of the Academia Sinica, and ladies and gentlemen. I feel very honored to be invited to give this lecture here today. As you can see here, that according to the World Cancer Report 2014 of the WHO International Agency for Research on Cancer, we can see that there is increasing global burden of cancer. And we can see from here that the number 1 cause of cancer death is lung cancer, and the second one is liver cancer. So I will focus on liver cancer. Since I'm a pediatric hepatologist, so I see patients of liver cancer, and I have reported around 32 years ago, these 2 families. The first family in the left side, it shows that the elder brother has an abdominal tumor, so come to see me. And I diagnosed this patient have liver cancer in his abdomen. And as usual, I screened the whole family and found that the younger brother, 7 years old, also have liver cancer. So very sad. And I screened the whole family. I found that the father, the mother, and also the younger sister are all surface antigen positive, suggesting a familial hepatitis B virus infection, chronic. So the second family here, the first elder brother come from Tainan to see me because of abdominal tumor. Again, I diagnosed this patient have liver cancer. And I screened the family in and found that the younger brother here also have liver cancer. And the mother, but not the father, have surface antigen positive, suggesting maternal chronic infection of hepatitis B virus status. And unfortunately, all these 4 boys died from liver cancer. Although liver cancer occurred mainly in adults more than 40 years old, but we see in Taiwan children have hepatocellular carcinoma, and the incidence seems more higher than many other countries. So we start to ask, what is the etiology of hepatocellular carcinoma in children? They are so young. And is hepatocellular carcinoma in children similar to that in adults or not? And what is the oncogenic process in the children because they go so rapidly? And how to control liver cancer? So we studied 51 hepatocellular carcinoma children. The age range is from 4 to 15 years old. And we found that there is a remarkable male predominance. The male to female ratio, 3.3 to 1. And 100% of them are surface antigen positive, suggesting a very, very close relationship with chronic hepatitis B virus infection status. And very high rate of liver cirrhosis, almost 74% in total, and even higher in the younger age, younger than 9 years old. So it seems the process of liver cirrhosis goes very fast, and with low positive rate E antigen. E antigen is a marker of active HBV, hepatitis B virus replication and infectivity, but they had already go to the high replication stage and enter the low replication status. So we conclude that severe liver injury and goes very rapidly with early ESO conversion to anti-E, and high rate of liver cirrhosis may contribute to the rapid development of hepatocellular carcinoma in these young children. In order to understand more about hepatitis B virus infection and the liver cancer in children and also in adults, we conduct further study, long-term follow-up study. We consider the family as a unit. We study the children, the parents, and the family members. We study hepatitis B virus infection long-term in children, starting from pregnant women and their neonates and their children, and follow up them every 6 months or even shorter until they achieve adult. So from mother to fetus to children and to adults. So here we establish the world's longest and biggest hepatitis B children follow-up system in the past 30 years. Now we studied hepatocellular carcinoma children and their mother's surface antigen status. We found that 93.6% of the mothers are surface antigen positive, very high. And the control group, children with hepatitis B virus infection chronic, but without liver cancer, 50% maternal antigen positive. So significantly higher in this hepatocellular carcinoma children's mother. We also studied the father, and we found that the paternal surface antigen positive rate, 35.7%, which is not higher than the control group 25% maternal surface antigen positive rate. So we understand that maternal surface antigen positive or the maternal chronic HPV infection status is a very important factor causing these children to have liver cancer later on. We also studied the male to female ratio. We found that all the age have male predominance, but very, very interesting that the very young children, 6 to 9 year olds, in the pre-adolescent stage, we cannot explain why the male to female ratio is so high, from around 3 to 5. We cannot explain this phenomenon by the androgen effect, so we think there must be other causes. So we have a brief summary that hepatocellular carcinoma in children, approximately 90 to 100% of them are surface antigen positive, suggesting the very important role of hepatitis B virus infection chronic in these hepatocellular carcinoma children in Taiwan. And remarkable male predominance in childhood hepatocellular carcinoma. And non-tumor portion, cirrhosis, very high rate, around 80%. So very rapid process of liver cirrhosis. And 94% of the mothers are surface antigen seropositive, suggesting very important role of mother to infant transmission of hepatitis B and the cancer. So we further investigate the genome integration status because HBV virus have a polymerase which has the function like HIV, but the reverse transcriptase function. So the HBV genome can integrate into the host genome. So we study the control group, chronic hepatitis B virus infection children. Their tissue shows 0% integration rate of HBV genome into the host, but 22% in the non-tumor portion of non-tumor tissues of the HCC children, and 67% in the tumor tissue, HCC tissues of these children. We investigate the HBV junctions and the franking cellular sequence in these HCC tissues in children by inverse PCR, and we found that the HBV DNA was integrated into the RBMY gene in our childhood HCC tissues. And RBMY is the RNA binding motif on Y chromosome. We demonstrate that RBMY is a novel liver-specific oncogene through the evidence in cellular and transgenic mice models. As shown here, our transgenic mice, after follow-up, they develop precancer lesion, the adenoma, and also the liver cancer in this transgenic RBMY transgenic mice model. And we investigate the liver tissues in human. We found that in children, 38% can have the messenger RNA expression of the RBMY. And in adult HBV, HCV, or non-B, non-C liver cancer tissue, 31 to 44% presence of messenger RNA expression of RBMY. And in hepatoblastoma, a fetal embryonal type of liver cancer, 67%. But in contrast, in the colon cancer, renal cancer, lung cancer, and stomach cancer, prostate cancer, none of them have RBMY expression. So it seems it is a liver-specific oncogene. And we further demonstrate the stemness of RBMY, and we found that in this human embryonal tissue, the fetus, 12 to 19 years old human fetus, we found that the male, M, the male, shows messenger RNA expression and protein expression by RT-PCR and Western blotting, but not the female. And this after birth, 7 months old fetus and adult, 38 years old adult, they lost postnatal expression of RBMY protein in the hepatocyte, but scarcely expressed in the bioductal cells in adult and the infants, and where the stem or progenitor cell reside. And here in the animal mouse model, we found that in the earlier fetal stage, RBMY expression, protein expression in the cytosol of the hepatoblast. But it decreased the expression, but the fetus became more mature. And postnatally, it disappeared in the expression of hepatoblast and scarcely expressed in the ductular epithelium, cholangiocyte. And here again, we can see that this fetus, male fetus, express RBMY protein in the cytosol. Fetus 18 weeks, 19 or 16. And here the cholangioblast. And we also find that RBMY protein expression is colocalized with the albumin and alpha-fetoprotein, the hepatoblast markers, and also colocalized with this CK19, the cholangioblast cell markers. And in cancer cells, in human cancer tissues, we found that RBMY expression in the cytosol of these cancer cells and colocalized with CK19 and apican, these cancer stem cell markers. And RBMY expression is restricted to the apican positive cells, as shown here, but not apican negative cells. So we think that RBMY novel oncofetal proteins. And upon hepatocarcinogenesis, cytoplasmic nuclear RBMY expression is increased and observed in the HCC tissues. And from this figure, we can find that the cytosolic expression of RBMY dominantly in hepatic cancer stem cells and correlates significantly with the decreased survival rate in our HCC patient. So, how to control cancer? The first strategy is cancer prevention. This is the most effective way to control cancer. The second, screening and early detection of the cancer. The third, we should provide effective therapy for cancer patients. And taking liver cancer prevention as an example, here we can see 3 levels of cancer prevention: the primary, secondary, and the tertiary prevention. Here we can see the primary prevention using hepatitis B immunization, targeting every healthy infants. So the target is the general population, and the cost is very low. The effect is high, and the time required is brief, just 3 injections. And adverse reaction is minimal, just a local injection pen. And the secondary prevention using antiviral therapy, targeting the high-risk cancer high-risk group, that is chronic HBV infected subjects, to prevent them to develop liver cancer. And the cost is higher, and the effectiveness is lower than the primary prevention. The time requires several years, and the adverse reaction, like using interferon, remarkable adverse reaction. And if you use oral antiviral agent, drug resistance may develop. And tertiary cancer prevention, also using antiviral therapy, and to prevent those already have liver cancer to have recurrence. If this cancer patient, the cancer is surgically resected or under local therapy. And the cost, the time required, and the adverse reaction are very similar to the secondary prevention, but the effect is the lowest. So, how to prevent liver cancer? I think cancer preventive vaccine is the best. Taiwan is in the world the first country to initiate the national HBV immunization program. Starting from July 1984, the high-risk neonates of HBsAg positive and mothers received first-generation plasma-derived vaccine. And 2 years later, in July 1986, plasma vaccine was given to every neonates. And starting from October 1992, the second-generation recombinant vaccine was given to all the neonates. If we want to know the cancer prevention effect in adults, we need to have around 40 years or longer. So we think maybe we pediatricians can do something to demonstrate the impact of HBV vaccination. So from our study, we demonstrated acute and fulminant hepatitis B is reduced. Chronic hepatitis is reduced by around 90%. And hepatocellular carcinoma is reduced around 70%. And this is the most updated data published this year. We demonstrated 7 serial thorough epidemiologic studies of our HBV marker study every 5 years, starting from before to after the HBV immunization program. And we are fortunate to have this baseline data in the springtime 1984, just prior to the initiation of our national immunization program. And we found that in children 2 years and above, the surface antigen positive rate is around 10%. And 5 years later, in those below 5 years old, the surface antigen positive rate is around 2%, so reduced. And if 10, 15, 20, 25, and the most recent one, 30 years later, we demonstrated those below 30 years old, the surface antigen positive rate reduced from 10% to 1% or lower than 1%. So reduction rate around 90%, so very successful. We also demonstrated in children 6 to 14 years old, the incidence rate of hepatocellular carcinoma is reduced after the vaccination program successfully. In contrast, the other kind of childhood liver cancer, hepatoblastoma, which is a fetal embryonal type liver cancer, often occur in children below 5 years old. The incidence remains stationary. We further investigate children and extending to adolescents, and we found that 6 to 19 years old children and adolescents, if we consider the hepatocellular carcinoma incidence, the incidence rate ratio as 1 in the unvaccinated birth cohort, then those vaccinated birth cohort, the rate ratio of developing hepatocellular carcinoma reduced to 0.3 to 0.32, which means a reduction rate of 68 to 70% of the hepatocellular carcinoma incidence. Since the incidence of hepatocellular carcinoma is much higher in adults than in children, and the protective antibody, the anti-HBs, against hepatitis B virus infection is waning with time after HPV immunization in infants. So we start to ask, can hepatitis B virus immunization in infants prevent hepatocellular carcinoma in both children and also adults? And the answer is yes. We just published this year showing that this cancer prevention effect can be extended into a young adult 20 to 26 years old. So the rate ratio is 0.42. The reduction is around 60% in this age, significantly reduced. And we also see the rate ratio in children 0.26, 0.34, and 0.37. So we start to think of whether the cancer preventive effect is lower in adults in comparison to the younger children, because this rate ratio is lower and this rate ratio is slightly higher. The answer is no. Actually, this is not an age effect. This is a birth cohort effect, because this earlier birth cohort, 1984, only they receive plasma-derived vaccine, and only high-risk infants are injected the vaccine. In the second birth cohort, 1986 to 1992, they received plasma-derived vaccine, and the coverage rate, I think, is lower than the later birth cohort. In 1992 and 2005, this birth cohort received the second generation recombinant vaccine, and the coverage rate of the vaccine is higher. So Taiwan's data demonstrate that hepatitis B vaccine is the first successful cancer preventive vaccine in human. The cancer preventive effect of hepatitis B vaccine in infants has been extended from children, adolescents to young adults. And this result can serve as a model for the research on the prevention of other viruses or bacteria or even parasite-related cancers. So in spite of the great success, still there are challenges. Still we can find vaccine failure cases. We also call it as breakthrough HPV infection after complete immunoprophylaxis. So we search for the causes. We found that the most important cause is the maternal factor. very high maternal viral load with positive E antigen and surface antigen, and also intrauterine infection. The second factor is a viral factor. The virus can develop the surface gene escape mutant. And the third factor, the genetic hyporesponsiveness to this vaccine and also immune-compromised host. So to fight against hepatitis B and the liver cancer, why should we start early in life from fetal and the neonatal period? Our teacher, Dr. Palmer Beasley and colleagues, published a very important data in 1975. Dr. Beasley done study for more than 10 years in Taiwan. So this study is done in Taiwan. He found that infants with E antigen positive mothers, 90% of them will become chronically infected surface antigen positive carriers. And later we done the study in infants of E antigen negative surface antigen positive mothers. We found that less than 5% of these surface will become surface antigen carriers. Most of them are uninfected or present with acute or fulminant hepatitis. And we spent around 10 years from 1984 to 1993 to collect 665 neonates of E antigen positive and surface antigen double positive mothers. And we found that the surface antigen seropositive rate within 24 hours after birth is 2.4%. So we think that because HBV virus have an incubation period of 6 weeks to 6 months, so we think they are intrauterine infection. So from the mother to the fetus and to the children, and then we follow up them to adult. We further studied the vaccinated birth cohort and found that vaccine failure rate in E antigen positive, surface antigen double positive mothers, children, 9.26%, almost 10%, very high failure rate. Even given hepatitis B immunoglobulin and the vaccine completely. And the second high-risk group, E antigen negative but surface antigen positive mothers, children, if without hepatitis B immunoglobulin at birth, according to our government's regulation, 0.29% vaccine failure rate. And if the parents pay by themselves the HBIG immunoglobulin at birth, then drop to 0.14%. So all these two are less than 0.3%, much lower than the 9.2%, almost 10%. So we understand that to fight against hepatitis B and the liver cancer, we should work further in this very high risk group. So using prospective study, we studied the pregnant women and test their viral load. We found that the highest risk group, the E antigen positive surface antigen double positive mothers, the HPV viral load greater than 6 log 10 copies per ml. In this group, 80%, very high. But in contrast, in this second high-risk group, similar viral load, more than 6 log 10 copies per ml, only 0.5%. So very much different. And here in the right side figure, the horizontal axis shows maternal viral load, and the vertical axis shows the outcome, the vaccine failure rate in their children become surface antigen positive. And children with a maternal viral load greater than 10 to the 7th to 10 to the 8th copies per ml would have a significant risk of developing vaccine failure despite immunoprophylaxis. For example, if the maternal viral load during pregnancy is 10 to the 9th copies per ml, then their children will have 30% vaccine failure or even higher. Because testing hepatitis B, HPV DNA levels in the pregnant woman, the cost is higher. So recently we studied whether we can use maternal hepatitis B surface antigen titers to screen the mother and predict the risk. We just published this result this year, and we found that yes, there is a positive correlation of the maternal surface antigen titers and the children's outcome, the percent of vaccine failure. We found that if the surface antigen level is 4, the failure rate is 2.4%. If the surface antigen level 4.5 log 10 IU per ml, the failure rate around 8.6%. And if the surface antigen titer 5 log 10 IU per ml, the failure rate is around 26.4%. We further studied the hepatocellular carcinoma patient, children, and adolescents, 6 to 19 years old, and we searched the data of the maternal prenatal surface antigen. And we found that if the mother is surface antigen negative, their children, if we consider the odds ratio of developing hepatocellular carcinoma as 1, then those mothers, surface antigen positive mothers, their children, the odds ratio for developing hepatocellular carcinoma is around 34, so very high, suggesting that maternal surface antigen indeed is a risk, very important risk factor for their children to develop hepatocellular carcinoma. So, how to overcome mother-to-infant transmission intrauterine or perinatal transmission of hepatitis B to their children? We should increase the implementation of hepatitis C vaccine first dose as followed by the recommendation of the WHO. Second, we should give hepatitis B immunoglobulin immediately, as early as possible, within 24 hours after birth, to neutralize the virus transmitted from the mother. And we can consider antiviral therapy for high-risk pregnant women during last trimester to reduce their viral load. So we have conducted clinical trial to study the effect of antiviral therapy in the 3rd trimester of pregnancy to reduce the mother-to-infant transmission. We found that we screened the maternal viral load during pregnancy. And when the maternal viral load is greater than 7.5 log 10 IU per ml, we enroll this mother under their consent. And we divide them into 2 groups. The treatment group, starting from pregnancy 30 to 32 weeks, antiviral agent, tenofovir disoproxil fumarate, TDF, 300 milligram per day was given until 4 weeks after delivery. And in the control group, no treatment was given. And we follow up the children, check HBV serum markers for both groups at 0, 6, and 12 months after birth. And this figure illustrates the maternal viral load. And the upper line shows the mother's viral load remains stationary in the control group, untreated group. And this treatment group, we found that the viral load declined from 8 log 10 copies per IU per ml to 4 log 10 IU per ml. And this is the time P0, the delivery of the infant. And this is the 1 month after delivery. And the yellow bar shows the treatment duration. And the titer return to the pretreatment levels when the drug is discontinued. And the outcome of their children, this figure shows HBV DNA level at birth. And the control group, 31.5% HBV DNA positive in their neonates' blood. And reduced 6.15 in the treated neonates. So significantly reduced. And this figure demonstrates the surface antigen positive rate at 6 months old. This represents the chronic infection rate in the outcome of their children. And in the control group, 10.7% and reduced to 1.54% in the treated group. So to fight hepatitis B and liver cancer, we should block maternal transmission starting from fetal and the neonatal period. So I would like to thank my colleagues in the National Taiwan University Hospital and the School of Public Health, National Taiwan University, and the research group, Genetics Research Center, Genomics Research Center, Academia Sinica, and Taiwan Hepatoma Study Group in the whole Taiwan, and Taiwan Pregnant Mother-Infant Transmission Study Group in the northern Taiwan, and Taiwan CDC and Health Promotion Administration Department of Health, and National Health Research Institute, and Ministry of Science and Technology. Thank you very much for your attention.
Thank you for the wonderful lecture. Are you going to accept any comment or question?
Yes.
Okay, any questions or comments? Any comment or questions? Yes, please.
Since you mentioned that you should start vaccinations in high risk, thank you, high risk mothers, who is at highest risk?
Yeah. At present, we screen the E antigen and surface antigen in Taiwan. In the world, there are many different strategies of the government in the world. Some countries just screen, like USA, just screen surface antigen. And some countries did not screen anything, just give the vaccine. But in Taiwan, starting from July 1984, we screen maternal surface antigen and E antigen. So we keep the potential to know who is the highest risk, the E antigen positive subject. Certainly we can see that 80% have very high viral load, still 20% have lower. So the government started to think whether we should screen maternal HPV DNA. But it takes some cost, so still thinking. So we study the surface antigen titer, see whether we can reduce the cost of the screening.
Okay, other question or comments?
Enjoy your talk. Congratulations for your work in the first human cancer vaccine. I have two quick questions. The first is you mentioned about only 75% or so male childhood hepatoma and 25% are female. So I wonder if the RBMY oncogene are they expressed in the female. How do you explain the oncogenic mechanism in the female hepatocellular carcinoma in childhood? And the other is like hepatoblastoma. They stay stationary without change. So in hepatoblastoma or female childhood HCC.
Yeah, very good question. We also think this question because we work for RBMY gene, which is a male specific Y chromosome. I think the hepatocellular carcinoma, the oncogenic mechanism is very complicated. Not just RBMY gene can explain. So RBMY gene can only explain the male predominance part, and cannot explain the female, the female's mechanism. And hepatoblastoma, which is a different kind of, is a fetal embryonal type liver cancer. Also, the males also increased the remarkable expression of RBMY messenger RNA and also protein. So I think maybe it also plays some role in the hepatoblastoma because it's a fetal oncofetal protein. So I think maybe also plays some role in hepatoblastoma. And after hepatitis B vaccination, certainly it's not related to hepatitis B virus infection, so the incidence remains stationary. And recently we found the incidence slightly increased.
The other question is related to the epidemiology. That I think 95% of the childhood HCC is the mother is surface antigen positive. So the other 5%, you think the paternal surface antigen has been checked? or is horizontal transmission?
Yeah, I think maybe there are other causes of hepatocellular carcinoma in children, but comparing with the around 60 to 80% hepatitis B surface antigen positive rate in hepatocellular carcinoma in adults, the hepatitis B virus role in childhood hepatocellular is much, much higher. But still, I think anything will not be 100%. So some, maybe 5%, or maybe their HBV viral load is very low, so we cannot detect because they already have low E antigen negative, core antigen very low states in the tissues.
Maybe a father should be brain.
Dr. Chen.
Yes, I know that Taiwan has nationwide vaccination 10 years earlier than most of the countries in the world. So they look into our long-term follow-up. And recently there's a saying that some college students, their antibody protection is getting lower and lower. And people say, do we need a booster dose? Is that get into some conclusion because the whole world will look into Taiwan's experience?
Yeah, thank you very much. The very important question. We often ask by the government and by the colleagues, when should we give the booster dose? At present, from the 30 years thorough epidemiologic studies, we still recommend no universal booster dose is needed. So we give this recommendation to the Taiwan CDC. But for the high-risk group, for example, our colleagues working in the hospitals, they often have needle stick, and many people, they have their family members are surface antigen carriers or with some risky behaviors. Still, they need booster. So we check the titer if they, we can give, but they have to pay the booster, not the government.
Yeah, I just want to ask. I remember before 1984, Dr. Beasley had two important data. One is to monitor those Chinese mountainous people of origin, and find that they had a very high the surface antigen, hepatitis B surface antigen to begin with, even right after birth. So did you also check those mountainous people, they because of host factors or some kind of strain of the virus, so that's why they have such a higher viral load to begin with. The second question is, I remember they tried to use HBIG to block the E antigen mother to begin with. So I was wondering, can we monitor those cohort, and later on in their life they have a lower viral load or not compared to the other one?
Thank you for the question. I respect Professor Beasley very much. I learned from him very much. He studied the mountain people. I didn't, so I cannot answer the question. But I know that they have a very high surface antigen positive rate. For those injected with, in the earlier trial, Dr. Beasley gave HBIG before the development of the vaccine. He gave HBIG, but we didn't follow the subject only with HBIG without vaccine. We didn't have the opportunity to follow them. But some Dr. Beasley clinical trial patient come to me before he leave Taiwan. He referred his patient to me, so I follow up some of his children, starting from birth.
Okay, any more questions or comments? Yes, please.
My question regarding the hepatoblast population in between 6 to 9 years old and 0 to 5 years seems the different percentage, right? So I want to know, does RPM, this gene, why it cause the oncogenic effect is more severe in 0 to 5 compared to 6 to 9? In terms of severity, maybe vaccination efficacy?
These two cancers in children are different. The hepatocellular carcinoma, the outcome is very poor because we still do not have effective therapy for this patient. So they often die. The mortality rate is very high. Unless they are diagnosed early, we can resect or with local therapy. But the outcome of hepatoblastoma is much better. They are sensitive, chemosensitive. So we use the CELPO protocol to treat this patient. We can use chemotherapy first and reduce the size of tumor, and then we resect the cancer. And the survival rate is quite good. So I think this two kind of cancer is different. And the hepatocellular carcinoma is related to hepatitis B virus infection, but hepatoblastoma is not.
Other questions or comments? Okay, I'd like to have one small question. This biomarker RBMY you discovered, did that gene have any mutation for the cancer patient, or just overexpressed and underexpressed?
Yes, I think they have some mutation in some patients, but we haven't looked in details in this mutation. At the present status, we study the oncogenic process, the mechanism, and the interacting proteins. So we haven't really looked at the clinical samples to see the mutations.
Okay, thank you. Any more questions or comments? Okay, no more. Let's thank Professor Zhang. Thank you. And by the way, I see many